All right. Well, good afternoon, everyone. We're happy to have Dr. Stanimira Kalaykova here. And she's an assistant professor of dentistry and director of postgraduate program in TMD and Orofacial pain at Radboud University Medical Center. And yeah, Stani, really happy to have you here with us today. I know people have a lot of questions about bruxism and TMD, so thank you for sharing your insights and knowledge with us.
Thank you, Selena. Thank you for inviting me.
So yeah, we can jump right into the question, or are there some short preface you want to say to everybody?
Yes, well, thank you for a nice introduction. I indeed work here at the Department of Dentistry at the Radboud University Medical Center in Nijmegen, the Netherlands. Next to education and a piece of research, we also have a very nice clinic where we see patients, and we have a quite large center, let's say, where we have patients referred with TMD and other types of orofacial pain or dysfunction problems. So therefore, I very much like this topic, and I'm very curious to hear the questions of the people. And I can imagine that those are questions that we probably also receive from our patients on a daily basis. So I'm curious.
Yeah, no, I really like the fact that you're not just a researcher, but you're also a clinician. So a lot of these things are very applicable, I imagine, to a lot of people. So the first question we have is, you've studied and published research about the effectiveness of muscle stretching for sleep bruxism. Can you talk a little bit about the main findings of that study?
Yes, this study is actually a part of the PhD research of a colleague of mine, that is Simone Gouw. She is not a dentist, she's a physical therapist, and she's working here at our dental faculty. And some years ago, she defended her thesis that is on the physical and physiological and physiotherapeutic aspects of bruxism. And one of the studies was a randomized control trial on the effectiveness of stretching upon sleep bruxism. So she did study only sleep bruxism, not awake bruxism. And the main findings were that, unfortunately, we did not see a beneficial effect of stretching upon sleep bruxism. And sleep bruxism we did objectify using electromyography during sleep. So that's a nice valid method that is used quite frequently in sleep bruxism research. So unfortunately, no beneficial effects upon sleep bruxism within the study that we did, but we did see a slight significant increase in the pain-free mouth opening. And that latter finding is actually quite logical, because when you stretch, you kind of, you shift the moment of discomfort or pain during stretching to a later distance in the mouth opening. So it's we think a quite logical finding. We actually wanted to study awake bruxism as well, because I can imagine that doing a certain exercise therapy, such as stretching exercises, can help people become aware of behavior and bruxing behavior, and maybe alter that during daily activities, during wakefulness. But the problem with awake bruxism is how to have a valid objective measure, how to quantify. And since that's still a problem, and it's nowadays still based on self-report, though there are some advances, but still it's based on self-report. We did not study awake bruxism, but only the sleeping part.
Yeah, and you also mentioned that the subjects for this study were pain-free, right? So these were people without any pain complaints, no TMD, and they basically just brux during the night.
That's true, indeed. That is an important detail. Indeed, the participants in our study were purely bruxing subjects, so with objectified definite sleep bruxism, as we call it, but no TMD, no comorbid TMD. So therefore, we cannot study effects upon TMD with this study. It was purely based on bruxism, indeed.
Yeah. Okay, well, thanks for that. And so the second question, again, in terms of people are searching for what could help them with this condition, what has research shown regarding effectiveness of Botox? I think we see it being used more and more, and some people have reported less effectiveness over time on their second or third injections. Could it be because other muscles start to compensate? What have you noticed in this area, Stani?
I assume that you mean the effectiveness of Botox against bruxism.
Yes.
I assume that's about bruxism. There have been a couple of studies, indeed, studying Botox, and we do know, based on these studies, overall that Botox can be effective to diminish the sleep bruxism activity. And again, I repeat, the sleep bruxism activity, not awake bruxism. And
Yeah.
so because of the same methodological difficulties, it's really difficult to quantify objectively awake bruxism. So most of the studies on bruxism are actually on sleep bruxism. So Botox can diminish that, but it is temporary. So the bruxism index can increase after some time, and we know from other research using Botox on other muscles that the effect is temporary, mainly usually lasting for 3 to 6 months. So we see the same pattern also regarding the jaw muscles and the jaw muscle activity. I must say that the studies with Botox are usually relatively short-term studies, so we do not really have a follow-up of like 1 year plus. It's usually, I think, 3 months, maybe 6 months follow-up. And as to my knowledge, I have not still seen a study that studied the repeated use of Botox and how this affects sleep bruxism. So that would be another thing, another interesting question maybe to do research on in the future. So if you would repeat in time, do you see, some people ask, can you maybe, if you have a couple of Botox treatments throughout the months or years of time, can this maybe alleviate sleep bruxism in time? We don't know yet, actually.
Yeah, but are you seeing that the time period at which Botox is effective, is it always constant across people and across time? How does that work, or what have you seen in your practice?
To be completely honest, in our clinic, we focus on the non-surgical, let's say, although Botox is just an injection, so you can doubt whether it's a surgical method, yes or no, but within the Radboud UMC, the oral surgeons actually apply Botox, so that's our neighbors, let's say. But of course, when we look at research, it's always based on groups of subjects. So it's like a sample. You have a sample of participants, so you see the group effects, and we know on individual basis that there can be variations, and that's also in daily life and in practice. Yeah, and if you ask me about the impression based on clinical practice, we do see quite a lot of patients that have had Botox at the oral surgery department, and still somehow it's not effective, not enough, or maybe there is comorbid pain, and so patients are not so much interested into alleviation of sleep bruxism, but pain alleviation. And pain is a slightly difficult issue. Then Botox may not be good enough, or not efficient at all in alleviating the other problems next to sleep bruxism. So there are a lot of factors involved, and if we talk about pain, pain is multifactorial. So it's not only bruxism that can be related to pain. And so it's not only treating the muscle activity that is the only way to treat pain. Let's say.
So what other things that you can do to help with the pain besides just reducing the muscle activities?
Yes, that's a very good question. Well, as we still consider that jaw behavior and muscle activity is one of the important factors, step one would be to search for strategies or apply strategies that help patients become aware of behavior and help them to control the behavior and control bruxism. But on the other hand, other factors can also be involved. For example, psychological factors that may also alter the experience of pain. Like, for example, we know from research that fear and anxiety is involved into the pain, how people perceive pain. So it could be helpful to ask the patient to keep a diary, a pain diary, and also try to, using this diary, also to try to find connections, which factors are related to increase of pain, fluctuations in pain when the pain increases, and are there other factors that are related to decrease of pain in daily life. And that can give some insight into which activities should be avoided, let's say, and which activities should be promoted in order to, in the long term, to have less pain. So to try to get insight into the etiology of the problem. That's the best way to would be to manage the etiology. And if that's not possible, of course, then you can also think of symptom management for relatively acute types of pain, so short-lasting, more heavy type of pain, then use of painkillers can sometimes be helpful. And if the pain, is it muscle pain or joint pain? So it depends on the that's a part of the etiology. For example, if the pain is caused by an inflamed joint in the patient with systemic arthrosis or systemic arthritis, then non-steroidal medication that also decreases the inflammation can be helpful. So really, if we know the etiology, then we would be also better able to manage the pain.
Yeah, so it seems like there's the etiology and then try to reduce the cost if it's possible. But then there's also the psychological factor, which I'm glad you explained, because I think when people, like sometimes when I hear, oh, pain is related to psychology, I immediately think of like the hysteria stereotype of, people think when you think something is painful, you're being hysteric about it. But I think what you're referring to is more of how our perception of pain influences, or how we perceive pain does influence how painful we think it is.
Yes.
I'm not explaining myself correctly right now, but we can edit this.
I think you formulated it quite nicely, and but actually I think the association between pain and psychological factors is even broader than that. Stress can also cause alterations in behavior. So it can also affect the way we activate our muscles. We can tense the muscles more than we are conscious of, And so there are many factors that can contribute to a vicious cycle
of pain,
in the relation between psychology and pain.
Absolutely. And I think some research talk about like catastrophizing, when you think, this pain is going to last forever, then the more you are going to perceive the pain as, 9 out of 10. Whereas if you try to objectively think of where that pain level was yesterday, today, and the next day, you might actually see, oh, it's not, it's something manageable.
Yes, true. Catastrophizing may cause fear of movement. That's one of the models that we see back in the literature. So, and when you catastrophize, you're afraid to move because that may cause damage, you think. But when you become inactive or immobilized, then you put also more tension. So it contributes again to more pain, and then you can catastrophize more.
Interesting.
So that's one.
It's so interesting because people catastrophize thinking I need to protect this area from being injured, so I don't move. But you're saying actually by immobilizing it, it's actually creating more tension, which can cause more pain into the area.
Yes.
Wow.
That is why we often collaborate with physical therapists and also psychologists, so that we can help patients get out of this vicious cycle. So to cognitively restructure the way they think, and to try to catastrophize less, and to come from the negative sphere into the positive sphere, and then exercise more in a proper way. So eventually, in the long term, to have better function with less pain.
Yeah, and for those who are listening who are not clear on what catastrophizing is, can you maybe provide an explanation, Stani, of what it is?
Oh, that's a psychological term, and as a dentist, let me think of the correct definition. I was not prepared for this answer, but catastrophizing basically means that that you think something much worse will happen than expected. Let's say so. So there some small accident happens that is not so bad. It's not the end of the world, but you perceive it as a really huge catastrophe, a huge problem that cannot be solved, and so then that creates like a negative spiral in the way you think and act and cope with situations.
So which apparently also affect your pain perception.
It can affect behavior and cognitions and thus eventually also pain perception. Yes, that's the model that we use, and we also see it back in patients in the clinic. And this is a general model, not only something that applies to the orofacial area, but I think in healthcare in general, and surely for musculoskeletal problems systemically, not only the jaw.
Yeah, absolutely. I think a lot of this theory also comes from chronic pain, which if you think about what the orofacial pain is, it is a subset of chronic pain. So certainly this model applies to it as well.
Yes, orofacial pain is a broad term, and it contains actually items that can be acute pain, but also indeed items that belong to the chronic type of pain. So it's a orofacial pain is a really quite a large area, let's say, that contains both acute and chronic. And I just wanted to add that as we just spoke about the role of psychology, patients sometimes tend to react in a negative way when we mention that a psychologist may help us in a multidisciplinary treatment, into a multidisciplinary management plan. And people think, oh, I must be crazy. That's why they want to send me to the psychologist. But that's not the way we think. It's really about having help with boosting some mental strategies, let's say, how to change, for example, catastrophizing issues for the better. So a psychologist can really help along with the patient for really practical issues, and like, for example, keeping a pain diary and searching for related factors that can help into pain management is something that a psychologist does, and that's really those are very practical strategies. And there is this saying that I also quite often use in the clinic. I tell to the patient sometimes, you know, the human body and the mind, they are related, and it's really into one. So body and soul, that's hugely related. And if you separate it, then you're dead, let's say. So it's, I mean, there are large interactions in between. So we approach patients always in a holistic manner. You can say.
Absolutely. And I feel like all the science, especially in the last 10, 15 years, have supported that there is so much relationship between, you know, the physical and the mental aspect of health, right? And
Yes.
Especially for things like pain, we used to think it's just because some acute physical injury, but now we know more about the effect of, neuroplasticity and
Yes.
all the other mental, psychological aspect of things on pain. So thank you for clarifying that.
Yes, and as you mentioned, neuroplasticity, there are now also a couple of studies in the last years using employing, for example, brain imaging, and there is this idea that bruxism is also related to neuroplastic changes in the central nervous system. So it's authors known in our field that have stated that bruxism may be an overlearned behavior, they say. So it's your brain learns that this is how it should be, so you keep on unconsciously doing it, and so it's the art is try to how to unlearn this behavior.
Yeah, absolutely. So I want to switch gear a little bit. We have a lot of questions about what's effective and not effective for TMD. One of it is what about the use of splints and mouth guards for TMD? Are they effective?
The use of splints and mouth guards. Well, there have been different studies, quite a lot of studies actually, on the effectiveness of a splint on TMD, and overall, let's say we know a splint has absolutely a beneficial effect in alleviating TMD complaints. I must say that TMD is not one disease. It is not one diagnosis. It's really actually a term that relates to several different entities. So it's like an umbrella term. So that makes it sometimes difficult to answer a question: is a certain treatment really effective in respect to TMD? Because TMD is not really one entity, but let's say overall we are positive about the effectiveness of splints. So splints are quite often used in TMD management in dental clinics.
Is there a mechanism of action in how splints is helping TMD? That's the first part. And then second part is, are there, because you mentioned TMD is sort of an umbrella term, do you see in certain subpopulation where splints are more beneficial than others?
The mechanisms of action, that's a good question. We have an idea in theory, let's say, but scientific proof is slightly difficult to provide. But we think that a splint makes people aware of behavior. So when you insert a splint in the mouth, then people become much better aware of bruxing activities. And some activities are even not possible when you wear a splint in the mouth. For example, biting on your nails with a splint inside is impossible to do.
Yes.
So that's a very good example.
Yeah.
You can clench on a splint though, so you can still clench on this piece of plastic in the mouth.
Yeah.
But you notice it. It feels different
Weird.
than clenching.
Yeah.
It feels weird compared to clenching on your own teeth. So that makes people aware, and therefore they decrease the habit. Some people have been thinking, could it be that TMD relief is related to the fact that you raise the bite or you change the occlusion and so on? You know, it's a kind of theoretical ideas which are difficult to prove. But generally, what we think based on clinical practice and science, I would say also, is that it's more of the awareness of the behavior than really changing the bite, let's say. So that's the main issue, that you change your behavior. It's really like a device that just helps you into that. But you can achieve the same effect using other strategies as well, like exercising. That's why we work. We collaborate a lot with physical therapists. But even just giving an explanation to a patient can already create awareness and already help. So just really communicating, defining what is the reason for the pain complaints, and giving some behavioral advice. That this can already help quite a lot.
Yeah. And are there a subset of patients where you see splints being more effective than others? Or I suppose you sort of mentioned but I'll let you answer.
Yeah, well, I must see, just trying to remember if there is a study that really compares effectiveness of a splint. Is the effectiveness larger into a subset of patients with joint pain, for example, compared to muscle pain? I cannot really clearly think of a study that did such a comparison, but generally in the clinic, anyway, we see more muscular pain, so more muscle pain. That's more frequent, frequent finding compared to joint pain. We do have also patients with clicking joints, for example, without pain, with or without pain. Those are also quite frequent. But if you just look at the two types of pain, joint or muscle, I think muscle pain is much more frequently the reason for people to seek help. And I think probably more research is done on muscle pain than on joint pain regarding the use of splints. So it's difficult to compare. It's like comparing apples with pears, but I think we have enough evidence to state that for both types of pains, a splint can be helpful.
Yeah.
Yeah, that would be my answer.
Okay. And sticking to the TMD, someone asked the question, can TMD be cured just by stretching and releasing the muscles that are holding tension?
Okay, that makes me think a little bit of our research with the stretching exercises.
Yeah.
Okay, just some remarks regarding the question. First, TMD is not one entity, but really an umbrella term, as I previously mentioned. So that makes it a bit difficult to think of what exactly do we want the cure for. Secondly, curing an entity. Actually, in terms of TMD, we talk about management and not so much curing, because some of the conditions can be chronic. For example, arthrosis in the temporomandibular joint is something that it's there, but it's we cannot reverse it, let's say. So therefore, we rather speak about management than curing. And when we talk about stretching, that is actually an type of exercise. It is actually a type of physical therapy exercise. So physical therapy in general has been shown to be effective in different TMD types, different TMD entities. So stretching can be a part of the physiotherapeutical management plan. So we are positive generally using stretching, but solely just stretching, only stretching and nothing else, no explanation, no behavioral advice and whatsoever. Then I think that's not a good plan. I would suggest that stretching is a part of one component of a multi-component management plan. So there should always be a good explanation, behavioral advice, and probably also some other exercises included into the exercise plan, let's say.
Yeah. And how does that, I'm always very curious about mechanism of action. And so in your view, how does this stretching or this physical therapy help with management of TMD? What does it do?
What does it do?
Yes.
Well, it can increase the range of motion. We did see, for example, in our RCT here, in our clinical trial with our colleague Simone Gauw, that even the patients were not pain patients, no really TMD, but just the sleep bruxism part. Still, when you stretch, you kind of increase the pain-free range of motion. So you exercise the range of motion, you exercise the mouth opening. And especially in some types of TMD that are accompanied by limited mouth opening, this can be very important to stretch. And there are stretching devices, different types of stretching devices on the market. And it's, to my mind, not so much up to what kind of device you use, but the strategies. Is this a good strategy for the patient? Yes or no? No matter really how you stretch. But it can help into increasing mobility, and it can, we think, theoretically at least, indeed counteract tension, help also people to increase their awareness of behavior of bruxism. And I think still, although we didn't study it, we couldn't study it, but I can imagine that applying exercise therapy, including stretching maybe, can increase this awareness and counteract awake bruxism. But it's difficult to study because we don't still have a very good, easily to be applied objective measurement of awake bruxism.
Yeah, absolutely. And I know TMD and bruxism are two different things, even though it can be related. We still have to figure out what is the causal connection between the two. But I think I just like how you say, you know, it's management, it's not curing, because some of these things are chronic and not necessarily an acute condition that we can simply cure. And I think the idea of a multi-factorial, multidisciplinary treatment, I think it applies, it seems like it, from what I'm hearing, it applies to both TMD as well as bruxism.
Yes, actually, for both TMD and bruxism, we say both are multifactorial.
Yeah.
At least the factors that are of influence upon TMD and the factors that are influence upon bruxism, it's not one thing, not one factor only, but it's multifactorial. That is why we always take time to speak to our patients, to really to ask them to screen different domains, let's say, really to get acquainted with our patients and try to think along with them which factors from which domains seem to be of influence upon pain or upon bruxism, and how can we help them to manage the situation.
Yeah. And so related to that, is teeth crowding or malocclusion something that influence or cause or related to bruxism?
So basically, the question is whether occlusal factors, let's say, are maybe causative for bruxism.
Specifically, teeth crowding.
Teeth crowding is the question.
Yeah,
that's an orthodontic variable, let's say. So one of the variables related to orthodontics and occlusion, let's say, in a broader sense. Well, we cannot confirm such a relationship. And that's the short answer. We think that bruxism is more centrally regulated. That's one of the one of the papers some years ago stating that bruxism is centrally regulated and not peripherally, meaning that it's something that is more comes from the brain, centrally from the nervous system, inducing this activity, jaw muscle activity, and not so much the teeth themselves or the way the teeth are positioned or the bites. We don't think the bite induces bruxism. It is really the central nervous system that does it. We sometimes do see in the clinics patients who tell us that they underwent some dental treatment and they received a new denture or whatsoever, and the bite changed, and the bite didn't feel well, so they were searching how to bite, and a lot during the day biting in different positions, and that, you know, this discomfort of having a new dental filling or denture or whatsoever can create behavior, because people are still not used to the new situation. So temporarily it can induce some kind of behavior, but it's really the behavior itself and not the denture. I have a good colleague here at the dental, our dental faculty, and he has this very nice statement. It doesn't really matter what kind of bite you have. It matters what you do with the bite, you know? So it's about the behavior.
Yeah, exactly. So would you ever prescribe like an orthodontic treatment for people with bruxism, any of your patients?
No, we absolutely don't do that, and I would actually discourage that, because it really doesn't matter what kind of bite you have. We see also a lot of people who have perfect dentitions, very nice bite, no malocclusions, no orthodontic deviations, no problems at all, no crowding whatsoever, and still being active. So this is absolutely not orthodontics aiming at alleviating bruxism or also alleviating TMD. That is not state-of-the-art treatment, so we would discourage that.
Yeah.
You can, of course, do orthodontics for other reasons, but not with the sole goal to manage bruxism or TMD.
Yeah, if you want nicer teeth, I guess that's what the orthodontics is for. And so continuing on our topic about, you know, different things that affect bruxism or TMD, someone asked the question, what is the relationship between posture and TMD? Can bad posture, a chronically bad posture, certain posture causes TMD?
That is an interesting area that has caused quite some discussion in the scientific, in the academic sphere, let's say.
Yeah.
Well, we have the believers and the non-believers, and I think when we come to this believer versus non-believer discussion part, then we know, oh, okay, we don't really have a clear evidence, let's say, to draw connections. So I find it kind of dangerous, to say yes, posture is related to TMD, because then you receive a lot of clinics and people who try to treat TMD by using, for example, different kind of shoes to, starting at the bottom from the shoes to try to
Sure.
align the whole body and that kind of things. And we just, let's say that the evidence rather points to no relation. So it is, we cannot state that posture is really a causative factor. And of course, you always have the one individual patient, and where maybe things are related, but the mainstream, we cannot state this. We do know that there is a functional interrelationship between the jaw muscle function and the function of the muscles in the head and neck area. So the interrelation between the neck muscles and the jaw muscles, we know that there is an interplay, but that doesn't still mean that complaints are necessarily related. So we should judge on individual basis. Regional connections are much more plausible than connections further off, like the feet and the jaw.
Yeah.
Do you understand what I mean?
Yeah.
It's, we do pay attention whether our patients next to jaw pain also have headache and neck pain, neck shoulder pain. So this top part of the body, the head and neck area, we do screen that. But it's difficult to speak about postural issues further away of the chain, let's say. So
Yeah.
that makes that is, I think, the reason why the topic is difficult to discuss, because you have some regional interactions, but then you have also people who literally
extrapolate it all the way to the feet.
yes, and then you get really very different type of treatments, and then it's a question of what's the evidence base for that? Is there evidence base for that?
But on this topic, are there convincing studies or results out there that show, how you hold your neck, shoulder, in everyday life could influence your jaw position, and as a result, your clenching behavior or TMD? Is there any studies that you've seen that's pretty convincing?
Well, we know that the way we open and close the jaw depends also on head posture, whether you have your head more into an extension backwards or flexion downwards. So that slightly changes the way you move the jaw, and also the way you bite the teeth. Vice versa, we know that when you are standing up, right up, and you're chewing, during the chewing movements, or clenching, like a simulated bruxing task, for example, then you get also a kind of a co-activation also in the muscles in the neck area that helps to stabilize the head while you are performing these movements with the jaw. So that's a part of the functional interrelationship that we are aware of. So that kind of studies we know about this interplay from that kind of studies. Does this answer the question, or maybe can you repeat the question to check if I missed something?
No, I think I think what you said totally makes sense, which is, there's an interrelation between your neck and jaw muscles, and that there could be a relationship between your neck and head posture and how you bite and how you open your mouth. But I think in terms of drawing it to whether or not fixing posture equals
fixing TMD.
yeah, fixing TMD is a different question.
Yes, exactly. So we know there are functional interrelationship, but the complaints like the TMD, like myalgia, muscle pain or joint pain, that's a different story indeed. So yes, we should be then careful with interpreting the results of these functional studies and extrapolating also to the clinics.
Yeah.
So individual judgment, I would say, would be the most important. So per patient, trying to estimate which factors, which behavior or posture, if you call it, can somehow contribute to the complaints, and whether this should be a part of the management plan as well.
Yeah. And I also want to get your thoughts, or in a way, it seems like a lot of the studies in both bruxism and TMD are made difficult by the fact that both are umbrella terms. So how do you know that you have the specific right patient population? And then from that study, how do you extrapolate it to the rest of the category, which might or might not have the same etiology, right?
Yes.
I feel like that's such a big issues for both conditions.
Yes, you're absolutely right. Bruxism is also an umbrella term, indeed, as you mentioned, because we have the awake part and the sleep part, awake bruxism and sleep bruxism. And sleeping is a physiologically totally different condition than wakefulness. So I remember even one of the colleagues in our field, a professor from Switzerland, he once said maybe we should even think of different terms for awake and sleep bruxism, because we still call it bruxism, and
Yeah.
people somehow think it's one and the same thing, but these are still
Too different.
two different things.
Yeah.
And TMD is a huge umbrella term, because you have the muscle pain, because you use a lot your muscles, you were chewing a lot of chewing gum, for example, and you have inflamed joint in a patient with a rheumatic disease, for example, or even a painful joint because of undiagnosed tumor. These are rare cases, but you already feel these are two totally different issues. Pain due to an oncological condition, and
Yeah.
muscle pain and muscle soreness due to chewing gum, but it falls under the umbrella term of TMD. And so the question is, should we keep on using the term TMD, or should we just become more specific and from certain points start using the specific entity term and not the umbrella term? TMD is like an ENT condition, I would say. It's like I have an ENT disease, ear, nose, and throat.
Yeah.
ENT is not a diagnosis. It's just like
the area.
You point towards the area, but not the condition itself. And also myalgia, which means muscle pain, and arthralgia, which means joint pain, is just actually a symptom description. It's not a complete diagnosis, because you have the complete diagnosis when you have the etiology as well. So is the joint painful because of trauma? The patient fell on the face and traumatized the joint, or is the joint painful because of a rheumatic disease, or is the joint painful because of a hidden oncological problem? And the treatment really depends on the etiology in the three examples that I just pointed out.
Yeah, just saying I have a pain here doesn't tell the full picture, because then you have to go back to what is causing the pain and how can you solve that etiology. Yeah.
Yes, that would be the ideal picture, to know the etiology and to be able to solve it.
Yeah. So I can appreciate how much time you have to spend with the individual patient, because it really has to be tailored to the individual to take their complete diagnosis and try to understand where is the pain coming from.
Yes, yes. I must say though that a few of the examples I just used, like oncological problems or rheumatological disease, these are actually the more the rare cases, let's say.
Yeah,
For people not to not to become afraid of, oh my God, I'm having also this tumor in my jaw. Those
sure.
are really rare cases. And working here at the academic hospital, of course, we see the top range patients, the most difficult complex cases. So we see them a bit more often. But I think in the first line patient care, for example, in the office of the home physician or the home dentist, those are really rare cases. So please do not think immediately, oh my God, I have some serious problem in my jaw. It's probably not the case. So just looking at prevalence, just to
Yeah.
give some
So
comfort to the people who listen to this interview.
yes, absolutely. And I think that's a good point. I mean, so prevalence wise, what is the most common etiology related to TMD?
Well, we think that the most patients with TMD complaints, just to use again the umbrella term, but overall it's an overload issue, let's say. So Bruxism related, so behavior related, we overload the muscles and therefore we get delayed onset muscle soreness, and that causes the muscle ache, or even you can clench or grind so much that also the joint becomes painful. This
Wow.
is the main cause that we think we see in our patients. Underlying clicking joints, for example, like a disc displacement, can be not painful, but sometimes it can contribute to pain. That may be on a second place, together with arthrosis, that can sometimes flare up and create a painful joint, or even muscle soreness around the painful joints. But overall, I think in the home physician or the home dentist office, the main reason would be this, what we call a-specific type of TMD problems that are more related to overload, to overuse, let's say.
Mm-hmm.
And rheumatological conditions or rare disorders or oncology, that's really very, very few patients. But still, the orofacial pain specialists need to be, of course, aware of all the different causes that can be there. So you always have to have a complete diagnostics, let's say, so to be able to have a proper idea of what's causing the complaints and the proper treatment, proper management.
Yeah, makes sense. And so with that, is there, I'm just looking through the question and see what we still have to answer. Well, this may be a fun, light-hearted question. What's the best way for a TMD sufferer to stay safe while playing contact sports? I suppose to avoid injuring or traumatizing the jaw area where it's painful.
Right. Well, the first thing that I have to think of is types of sports where people use like a mouth guard to protect the teeth. So that is maybe step one, let's say. That kind of mouth guards are usually prefab, so not customized, not individually tailor-made. And they usually do not fit so well. So they're either too loose, or maybe they cause discomfort because of some pressure areas. And if you would have, so imagine you are a TMD patient, you have muscle complaints or joint complaints, and you wear, let's say, a loose a prefab, non-customized mouth guard, then if it's loose, then probably you need to bite it frequently in order to keep it on place. Otherwise, it will fall off.
Yeah.
That actually induces bruxism, and that can aggravate the TMD complaint. So in this case, it is important actually to have, you should rather have a professional, customized, well made, individually for you, well fitting, not too loose, no causing discomfort, so that it protects the mouth without creating side effects, let's say. And also you can have like a prefab or maybe even a boil and bite type of mouth guard. You have these boil and bite guards that people can make, boil themselves at home and try to make fitting in the mouth, but usually it's very difficult if you're not a dentist to make such a thing well fitting. And it may be not too loose, it may stay on place, but probably it will not fit the dental arches good enough, and it can cause orthodontic side effects. It can cause thereby the teeth to move and migrate. And that is unwanted, of course. So it would be a pity to create such a side effect. So that is again a reason for me to advise rather have a professional, customized mouth guard made by a dentist, and not just prefab or boil and bite made by yourself at home. So I think that's the main issue with using guards, let's say, during sports. I think the mouth guards are quite frequently used, and usually, unfortunately, not a good customized type.
Yeah.
And of course, you have some contact sports where hitting is involved, and then you can wear a helmet or something like that. But that's these helmets are, I think, available anyway.
Absolutely. Okay. And then someone asked, I think this is sort of related to the posture question too, but more specific. So is orofacial myofunctional therapy and tongue position effective in reducing bruxism?
Okay. Well, now I actually realized that maybe the term posture I didn't completely interpret in the same way as you did, or the person who asked the question did, because when I hear posture, then I think of bodily posture in general, like from the feet to the top. But if you talk about posture of the jaw, like how you wear the jaw, let's say, how you behave with your jaw, how you place the jaw, whether you test the muscles together with that, that's a different issue, because it is related. I mean, if we think of a connection between bruxism and TMD, then of course the way you use the jaw, how you place the jaw, that is directly related also to tensing the muscles, and therefore jaw muscle activity. That is the definition of bruxism, because bruxism is defined as a repetitive jaw muscle activity. Other being than disorders, let's say, but
yeah.
So,
but is your tongue, where you put your tongue, affect that jaw position?
There is an interplay indeed between the muscles here in the orofacial area. It's a kind of a similar situation, like the connection between the function of the neck muscles and the jaw muscles. So people who do tongue thrusting, so like putting pressure with the tongue to certain spots in the mouth, that co-activates slightly also the jaw muscles. So there is a slight enhancement, let's say, of bruxism actually. So be a therapeutical approach, like physiotherapeutical approach, using different types of exercises that directly approach the muscles in the orofacial area can, of course, be beneficial, I think.
Yeah.
Yes. And then if we look at evidence, a lot of bruxism research is really focused on sleep bruxism and not on awake bruxism. And that makes it difficult to give a reference of a study that shows the effectiveness of that kind of certain type of physical therapy, like the types of therapies that you just mentioned in your question. We don't have this evidence, but it is a kind of from a clinical point of thinking, clinical reasoning. It is related, because if you can make the patient aware of the behavior and make sure that the behavior diminishes, then it can help. But we do know with some studies, like for example that I gave the interplay between the neck and the jaw muscles. These are studies with during wakefulness with simulated tasks. So ask people to clench, and then you see the EMG going up and down together, the jaw and the neck muscles going up and down together. So that kind of co-activation issues, we know that this interplay exists. By the way, looking back at the study, a PhD study of Simone Gouw, our colleague, she did study this co-activation as well, but then during episodes of sleep bruxism, and she also found there this interplay, this correlation.
Interesting. Yeah, and I would assume that with this orofacial myofunctional therapy, it's the same with what you talk about and how physical therapy, it counteract the tension and make people more aware about where their where their jaw position is, make them aware of the behavior, and also stretching so that they have more mobility. I assume it's sort of similar parallel as well.
Yes. Well, I think stretching and exercises related to tongue position, and it's all a part of a physical therapeutical approach. In the Netherlands, we have this thing, the speech specialist, the speech therapist, the logopedie in Dutch. And those colleagues are also busy with the mouth, the way you speak, the way you pronounce the sounds, and so on. So even certain colleagues of that area are also aware of the existence of TMD complaints, so they can also help with speech-related strategies or singing and so on to modify the behavior of the mouth and the jaw.
Yeah, absolutely.
So there are quite a lot of disciplines busy with the temporomandibular system.
Yeah, it makes it a very interesting area, definitely, with a lot of disciplines approaching it from different angles. So we've talked a lot about awake bruxism versus sleep bruxism, and of course with awake bruxism, being aware about the movements and activities that increase the tension and overloading certainly will help. What about sleep bruxism, grinding and clenching at night? What can one do to reduce these activities at night? Because you're asleep, you're not totally in control of what you do at that point in time.
Yes. Well, my first step would be first to screen for possible factors that are related to sleep bruxism. So are there certain factors that can enhance bruxism, sleep bruxism, yes or no? And are those factors modifiable?
Okay.
If we look at the knowledge that we have, the evidence that we have related to the possible etiological or risk factors, I would say, for sleep bruxism, then we have a category of psychological factors, for example, stress and anxiety, I think, are maybe the main factors that we have some evidence for. We have a group of factors that are related to substance and drugs use in terms of medicinal drugs or really drugs like alcohol and amphetamine, ecstasy pills, and so on. That can enhance sleep bruxism, and a group of sleep-related factors. So in terms of psychological factors, I just mentioned maybe stress and anxiety, these two most important factors. And we know also that stress factors can also cause disturbed sleep. So you can have psychosomatic arousals in your sleep. So there is an influence upon sleep, and through the influence upon sleep, through the occurrence of more frequent arousals that can also cause you to be into more frequently into your less deep sleep. Let's say that kind of the sleep phase that you have more chance of bruxism. So being more frequently into that phase and undergoing more frequently arousals can enhance bruxism. We think that's a concept. If we look at substance use, I just mentioned amphetamine use and related substances. So the ecstasy pills at parties. So even our dental students know that sometimes when they go to these parties, they use these drugs, and then they have to grind some more. So they sometimes ask for if they can have a splint to protect the teeth, so that they can still go to these
parties.
So it's from the clinics. Let's say we know this effect. But also not drugs in terms of party drugs, but even daily substances like drinking too much coffee. Like there were some studies showing that drinking more than 6 or more than 8 caffeine consumptions per day that is related to more reporting. It is reporting, so self-report, but still it is reported significantly more. Nicotine, smoking could be related, alcohol could be related, some studies say, but also drugs in terms of medicinal products in the treatment of certain conditions, like the selective serotonin reuptake inhibitors, that class of antidepressant drugs, or medication for patients with attention deficits hyperactivity disorder. The ADHD medication is actually amphetamine-like type of drug. And that is also has been related to enhancement of sleep bruxism. So the question is, is there substance use? Can this be changed? If you have a patient with ADHD, then the drug is needed. So we, as dentists, we cannot say you should stop with this drug because other, maybe bigger problems will appear then. So we should not, I think as dentists, we should register that's a fact, but it's probably the psychiatrist or the home physician who prescribes this medicine. So as dentists, I think we should not interfere with that. In terms of antidepressant use, then you could maybe ask the home physician or the psychiatrist if switching to another group of antidepressants, because it's not only this SSRI antidepressants, you have other classes as well. If that is possible for the specific patients, yes or no, but do not initiate the stop of medication because I think it's not up to the dentist. If the patient uses drugs just for in terms of party drugs, then maybe that is modifiable because there is not a medical reason to take the ecstasy pills. So that's a matter of a lifestyle change.
Yeah. Absolutely.
So that is then a more modifiable factor. And then if we look at the third group, that's the sleep-related issues. Well, I touched upon a bit because of the psychosomatic arousals. That's an interplay between psychological and sleep factors. But we know that other sleep disorders can also induce at least a part of the bruxism episodes. Not all sleep bruxism explained by that, but it can enhance or it can add to it. Sleep apnea has been in the past few years in the spotlight. So the fact that there is less oxygen coming in because of this stops or decreased airflow due to the obstructive sleep apnea. So that creates an arousal and as a warning signal that your body activates and your jaw muscles activate as well. But also reflux could be related to such arousals. So when stomach acid enters the esophagus, that it can also become an alarming signal, and your body can activate. So there's, I remember one study some years ago already that actually they simulated reflux through infusions of acid into the esophagus, and they showed also bruxing events occurring within 20 minutes after this infusion. So
is it to stimulate like saliva production, sort of like our body's response?
Well, this is one of the interpretations that was given, that maybe bruxism then indeed is like a protective response to counteract the acid, but we don't know it. It's a speculation, and the thing is, if this acid also reaches the mouth cavity and the teeth, then your teeth are kind of softened due to this erosive acid.
Yeah.
And if you, within 20 minutes, that is quite short after the infusion, so you kind of start bruxing while your teeth are still softened, that can create more tooth wear. And we know if you have had acid in the mouth, the animal softens a little bit, and it takes time for it to become hard again, to remineralize again. That's a difficult word to say, sorry for that. And it takes usually longer. So then it's questionable whether bruxing, if you make tooth contact upon the softened tissues by the acid, if that really protects, or it can actually rather be the explanation why people with reflux have more tooth wear, because of the erosive factor and then grinding on top of it. So it seems like you would first think, oh, it's a protective action, but if you think more, then I think it's questionable.
Yeah. Makes sense.
But anyway, it is, I think, for the dentist important to screen also for sleep-related problems, and so different factors in sleep, like apnea, but reflux as well, or maybe even if you have a small kid, a baby crying now and then at night, maybe your partner goes up and gives feeding to the baby, and you lay in bed, but you may undergo these arousals and maybe have more chance of sleep bruxism. So that's kind of different factors. It's like a theoretical concept, but it may be related to periods of enhancement of sleep bruxism due to these factors. So if we screen for these factors and then try to check, can we alter these? Are there factors that are modifiable? Then we can try to modify them. And if not, then we use splints to protect the teeth. And well, the recent review articles have stated that it seems that a splint, although it's a peripheral type of treatment, it still can, it seems that it still can alleviate somehow the EMG activity, let's say, the sleep bruxism activity. So it is still worthwhile to use a splint. And we also advise to patients before they go to bed to follow sleep hygiene advice. It's a bit questionable to which extent this really can help into decreasing bruxism. One study with small numbers said, well, not a significant difference, not really an effect, but still, I think it's still worthwhile to follow these advices. Don't drink coffee too much too late
before bed. Yeah.
Before going to bed, you know, don't try to solve big problems in your head before going to bed, because it's likely that you still like go stressed to bed. So try to be relaxed before going to bed, and have a dark room, not free of noise and that kind of thing. So make sure that you sleep well. Make sure that you have a good quality of sleep, enough amount of sleep, and so on. If it does not decrease sleep bruxism, at least it will increase your quality of sleep and quality of life. So it's still worthwhile to do it.
Absolutely. So I just have one last question, Stani, because I know we have to wrap up. Related to this, do you have any perspective on whether biofeedback could potentially help with bruxism, awake or sleep?
That is a good question, and actually I forgot to mention it in the answer of the previous question, because indeed in the last years there are several studies about the effectiveness of biofeedback upon sleep bruxism. As far as I know, very few evidence related to awake bruxism because of the reasons mentioned before, the difficulty to quantify awake bruxism. But relating to sleep bruxism, there have been some studies with, for example, this contingent electrical stimulation in the temporalis area. In the first, I think 2-3 studies with some conflicting evidence, but the overall, as some studies were done later on, it could be effective. It is, though, important that biofeedback therapy does not interfere with sleep structure, let's say. So it is important to also to control. So if studies are performed about the effectiveness of biofeedback during sleep, also the sleep structure, the sleep architecture, so using also EEG and that kind of techniques is important, because you don't want to create as a side effect another sleep problem, let's say. So that's a safety aspect, and I think that some of the studies with this contingent electrical stimulation, they also checked for that, and the authors stated that the method they tested was safe in terms of sleep architecture. So that seems promising, but it's an aspect to always to control for in future research.
Yeah. And do you have any perspective on whether it could help with awake bruxism as well?
Well, the issue there is that how to quantify awake bruxism. So that's the first issue. How to quantify awake bruxism, and on the other hand, awake bruxism, how to say, a feedback management in wakefulness, I think it may be more successful compared to sleep bruxism or things that happen in sleep, because people become aware of what is happening, and they are able to control their behavior. So in this sense, I think if we can also quantify and measure awake bruxism, I think biofeedback management can be successful. And actually, in some physical therapy practices in the Netherlands, there are also these myofeedback equipment. So patients receive electrodes on the jaw muscles, and they can see on the screen that when they clench, the muscle activity goes up, and when they relax, it goes down. So that way they visually learn how to relax. So they learn what is the difference between tensing the muscles and relaxing the muscles, and that is a way for the patients to learn.
Interesting.
So that is one way, but okay, it's, then you wear the electrodes, and you do it when you're at this physical therapy practice and not at your own home. And a lot of behavior and activities happen when you're not aware. You're busy with work, you're behind your computer typing it, or phoning with your colleagues or whatsoever. Then you don't know what you're just at that point. You're not thinking of your jaw. You don't know what you're doing. And so feedback from colleagues, so evolving people to help you with feedback can be helpful. And since a couple of years, we also have this method called based on ecological momentary assessment that is using a smartphone application that sends you now and then at random moments messages and asking you, are you clenching or grinding right now at this moment? So then you score yes or no. And after multiple points, and so you gather data at multiple time points, and then eventually that gives you like a score, how often you were bruxing, yes or no. But the most important is it makes you aware, because after 10 times being caught like clenching, and you realize, oh my God, I answered 10 times yes, so I must be clenching much more than I thought. So that creates the awareness. But still,
I'm laughing because to me it's it's me and slouching, right? Like sometimes I don't notice that my posture is just so bad, and it takes like these gadgets that reminds me every so often whenever I start slouching to realize like, wow, I'm actually slouching all the time. And I think it's similar with some of these overlearned behavior, unaware habit.
Yeah, if we talk about overlearned behavior like a habit and no underlying disease, because also bruxism is defined as it is a repetitive muscle activity, but not other than neurological underlying diseases. So if you exclude that, so it matter of habit, I can imagine that feedback from people around you, family members, or that kind of gadgets that help you could be helpful.
Yeah. Yes. Okay. Great. Well, it's been more than an hour, Stani. Thank you so much for, answering all of these questions, being super generous with your time and your knowledge. And thank you for everything, all the research and the clinical work that you do. It's amazing to see how complex this subject is. And the fact that it really has to be like an individualized, personalized diagnosis, treatment plans, and also multifactorial and multidisciplinary in its approach. Can you talk a little bit, like what research are you doing at the moment? What are you most excited about?
Research at the moment. At the moment, or the recent past, let's say, we have had the bruxism studies. Right now, we have a very good collaboration here within our dental department with the colleagues that are dealing with tooth wear. So the connection between bruxism and tooth wear is very interesting. Also reflex, but also sleep apnea. We know sleep apnea patients have more chance of bruxism and more chance of reflux, and these two factors are theoretically also related to, we think, to tooth wear. So that's an interesting pieces of the puzzle coming together.
Yeah.
I'm very much interested into orofacial pain as well, which is a more difficult area to study because of the so many factors of influence upon pain and pain experience. I'm also interested into dental aspects and orofacial aspects of systemic diseases, systemic conditions. For example, some rheumatological conditions that can affect also joints. Think about juvenile arthritis in kids that can also affect the temporomandibular joints, but also some more rare conditions like scleroderma or systemic sclerosis, where you have tightening of the skin and also tightening of the skin of the mouth, and also more chains of arthritis as well. These are just a few examples. Or let's give another one. That's another disease that we have at Radboud UMC here, like a expertise centrum, expert center.
Yeah.
It's not. I'm missing the right term. Anyway, it's a European initiative to appoint in each country academic hospitals where expertise is concentrated related to a certain rare disease. And here at Radboud UMC we have the systemic sclerosis team, and we also have a team that is busy with Marfan syndrome. That's a connective tissue disease. And when you look at the literature, then you see that there are patients with the syndrome of Marfan, they are also prone to certain dental or facial characteristics, like typical long faces, small jaw, backward positioned jaw, and that also can compromise the airway and increase the chance for obstructive sleep apnea. So here you see again the link to orofacial problems, and maybe even indirectly through the apnea, maybe even bruxism. So that kind of I find it quite fascinating to learn about how the whole system works.
Yes.
And I think certain diseases can also teach us, can show us how the human body and the related mind as well work. And also give us some explanation of mechanisms of action. So.
Absolutely. Well, thank you so much. We look forward to reading your findings in this very, very interesting research. And thank you again for your time, and I hope you have a great afternoon.
Yes, thank you. Thank you very much, Selina. Yes, bye-bye.